Hi, my name is Lauren Brown. I'm a doctor of traditional Chinese medicine. My practice is AcuBalance Wellness Center, and it's located in Vancouver, British Columbia, Canada. It's called acubalance.ca. And today I'm going to ask a few questions to Dr. Paul Magarelli. He's a reproductive endocrinologist. His practice is in Colorado Springs, Colorado. Dr. Magarelli, I've gotten to know Magarelli over many years. He's spoken at the Integrated Fertility Symposium in Vancouver. He's offered lectures online and in person to acupuncturists and naturopaths to integrate with reproductive medicine, IVF, etc. He travels around the world to lecture. He's got chapters in medical textbooks, and he's done research and continues to do research on integrating acupuncture and other natural modalities into IVF with the hopes of increasing the IVF success. So I thought, since this Infertility Awareness Week, we actually call it Infertility Awareness Month now, the month of April here in Canada, that we'd have this discussion with Dr. Magarelli. And actually, we're going to keep these videos up because even though it's because it's Infertility Awareness Week and month, this information is valuable to any man or woman who are trying to conceive any time of year. So Dr. Magarelli, welcome, and thank you for making the time for our discussion today.
My pleasure, Lauren. And yes, it has been a wonderful journey with you and the acupuncture community over the past, I think it's more than 10 years now.
It's crazy. It has been a while. So I want to jump in on kind of where the technology is today and talk about comprehensive chromosomal screening. It's been called pre-genetic screening. Please let us know what the scientific term is today, because I know they've adopted kind of the term and the acronym they want today. The question I want to ask you around this, as you give us the right terminology, is there's been some news articles about women are throwing away potentially good embryos, but they're coming back that they're not normal. And I kind of want you to kind of give us where this technology is today and really which kind of women will benefit from this technology of doing some chromosomal testing, and how are you using this in your practice today?
It is a good question today. There is some controversy about this. The correct term now is PGTA, which is pre-implantation genetic testing for aneuploidy. There's a PGTM, other designations, but that's the one that sort of supplants PGS, supplants CCS. So the real term is PGTA. Its goal, first and foremost, is for us to better select embryos that have a greater potential for implantation and normal embryo development as well as fetal development and normal birth. You can't argue with the idea that putting abnormal embryos into the uterus really does no one any favors. Historically, we never had the tools to be able to determine if embryos were chromosomally normal or not, and therefore we did the best we could. And to answer your question about its value, let's go back to when we didn't know about PGTA, and it's very simple. If you look in the United States, the CDC, SART, these are organizations that monitor pregnancy rates based on age in IVF centers, and it's a legal requirement. If you look between the 80s, 90s, 1980s, 1990s, pregnancy rates hovered around 30%, 1990s to 2000 around 35 to 40%, and 2000 to 2016, which is the latest date for the reporting, it has stayed at 40% pregnancy rate in the ideal population, which is less than 30, of course, and then going down from there. So anything that can increase that 10% from 40 to 44% would be considered significant, since there have been no changes. And part of my research on acupuncture with Diane Credenda was this idea that we could actually increase pregnancy rates 15% by simply adding acupuncture. So that was revolutionary at the time, and that's over 10 years ago. With the advent of pre-implantation genetic testing, we now can tenfold increase pregnancy rates in women over 40. So they can go from a historic 4% to 40 or 50%. Now, how do we do it? Simply, we determine if the embryos are chromosomally normal before we put them in. How do we do that? Well, the embryo that we put in is a blastocyst. It has two parts, the baby part and the placenta. They all came from the same cell. So the presumption was, and still is, that the chromosomes in the placenta part of the embryo is the same as the chromosomes in the baby part. That's the presumption. So if we take some cells from the placenta part, it should represent the baby part. And lo and behold, you've seen this dramatic increase in pregnancy rates in all ages of women from 20 to 45 at numbers that dwarf what we've done historically. So where's the problem? It's incomplete, like all medicine. Nothing is perfect, like all medicine. So are there going to be times when the placenta part of the embryo does not reflect the baby part? Absolutely, and vice versa. You may get a placenta part that says the embryo is normal, but the baby part is not. You might get the placenta part that says the baby is abnormal, and it turns out that the baby part is normal, and they self-correct. It's a numbers game. We're measuring 10 cells out of thousands of cells. And so there's a bias in the selection of the cells with which we have no control. So the big issue that worries women now is the one or two criers in the night that, especially out of New York City for some reason, that have explained that, yes, sometimes you can put in abnormally tested embryos and find a normal baby. That is a rare event and an expected event. It is not surprising. If a patient doesn't ever want the risk of not transferring a embryo that is normal, then she should not do PGTA, because we spent 30 years not doing PGTA, so please don't spend the money or the time and simply put the embryos in, is my philosophy. As to what ages benefit, well, in terms of aneuploidy, abnormal embryos, and causes of miscarriage, these all accelerate after age 30, 35, 40, 41, 42, 43, 44, such that many studies have looked at embryos made in women over 45 and 100% are abnormal. So the best woman to advantage this would be those women over 40 who have a very high risk of transferring a truly abnormal embryo. I think I can go on for hours, Warren, but did I answer your question?
That does answer the question, and I think I'll add, because we've seen in our clinic, the clinic that we're with in Vancouver, if somebody has a history, they're young, but they're having a history of recurrent pregnancy loss, and they're like, I can't go through another loss. This is also what you do as well for the testing, I assume.
No, actually, I do it on everyone. I don't have that limitation. But yes, the first studies that were done with randomized controlled trials with a type of PGS, which was called FISH, F-I-S-H, fluorescent in situ hybridization, those patients benefited the most and statistically better outcomes when they did FISH. Today we know that PGTA can help everyone from age 20 to 45, and the big impediment to the utilization is how some practices, not my practice, how some practices almost double the cost of IVF by simply adding this wonderful test on embryos.
And so in your practice, it's the norm that everybody would have this testing, and we'll talk as later, you've made it more affordable, because I think that's the barrier. Actually, I'm going to, tell me if I'm quoting you, but I think in one of our discussions, you believe that the future is everybody will have this genetic testing. It's just the cost that's keeping it from everybody having it right now.
Well, absolutely. And I would love to say that 100% of my patients utilize it. It's about 86%. The nation's utilization is around 30%. And again, the number one reason folks don't do it is the cost.
Okay. And just the question we get, so to help put some of these men and women at ease, a lot of them are concerned that you're going to hurt their baby, but to clarify, you're taking from the placenta, not from the fetus. And so there is not a real concern of hurting the baby. There's always a risk to any procedure, but this generalization that a lot of women say, my baby's not going to have an arm because you took the cell for the arm idea.
Well, correct. That is a fear, and of course it's science fiction. Every cell, when you first make an embryo, is called totipotent. Every cell can make a whole human being. That's how you get identical twins. You don't get identical twins with one right arm, one left arm, one left arm. You don't, because those cells have the total potential to make a whole human being. And then as we get to the blastocyst stage, we have differentiation of duties. There's the inner cell mass. It's not really a baby yet, but it's going to be the baby. And then you have the trophectoderm, or the outside, which is going to be the placenta. So we wouldn't, right now, I could never say never, but I don't think anyone would take cells from the inner cell mass where the baby is to do testing. It's counterintuitive. There have not been increased incidences of negative outcomes from chromosomal testing. As a matter of fact, this goes back to my point. We double, triple, and sometimes tenfold increase the chance for one healthy baby by testing the embryo, not by not testing it. So yes, there's always going to be fears. That's what parents are supposed to do. But believe me, we as reproductive endocrinologists have even more fear.
Dr. Mack, thank you for answering this question. And for those that are interested in more information on PGTA, again, you can contact the Reproductive Medicine and Fertility Centers in Colorado Springs, Colorado, because they have lots of information on that.